Good morning.
Good morning, Dr. Alsaati.
Hi, Akanksha. How are you?
Good, how are you?
Good, 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 good.
Thank you for joining and thank you
Of
for taking
course.
time.
Of course, of course.
How have you been?
I have been okay, very well. Busy with kids' activities. I have three boys. I
Oh, wow.
know.
Yeah.
How about you?
Yeah, same here. I have just one boy. So,
Alrighty.
yeah.
Sure. They make our lives full.
Oh, yeah, definitely. All right.
Um,
Let me make you co-host so you can share your screen. Now you
okay.
can share your screen.
All right. Let me just open the cases. Are the people in already?
So there are a few people in right now.
Okay, good. Okay, great. So let me take the path presenter. All right, let me go back to the Zoom. There it is. And hold on. All right, so I'm gonna share my screen and it's
Sure.
going to be, oh, hold on, just a second. It's okay, honey, just leave it. That's fine, perfect, thank you very much. Close the door, please. All right, now I can, sorry guys.
Don't you worry, you just take your time. We are all in Sunday at leisure.
All right. Every time I put share screen, it doesn't show me the presenter. But anyway, can you guys see my screen now?
Yes.
And it's the past presenter.
Yes, yes.
Okay, okay. All right. So now we go to gastrointestinal. No, what am I? GU. Okay. Okay. So we stopped yesterday at case number 30. Today we're going to start at case number 31. Okay. So let's see. All right, so what am I looking at here? On low power, there's expansion of the submucosa, obviously. Now we have to go to the epithelium to see the location of that polypoid lesion. It seems like I have foveolar on the top, so I'm looking at some sort of a small bowel, I'm sorry, a soft tissue lesion within the gastric mucosa. I look further down, I have a lot of vessels. So again, I don't want to forget anything about my epithelium. My epithelium is very crucial. I look for IM before I move to the, elephant in the room. I look for IM and I look for signet rings in my epithelium. And I don't see anything there. And then now I move to the base of the lesion, which basically is very striking. It's very vascular. It's very eosinophilic. See, there's lots of eos scattered everywhere. So first thing that comes to my mind is inflammatory fibroid tumor, which basically is ectatic vessels, lots of inflammations, lots of EOs, okay? Let me look what the case info is and see. So yes, gastric inflammatory fibroid tumor. And let's talk about the microscopic. It's admixed bland cells, spindle cells, inflammatory cells, eosinophils, blood vessels, and the submucosa, expansion of the submucosa. The spindle cells are arranged in an eccentric fashion around the vessels. Yes, you can see that as something that you can be classic for this, but honestly, it's not something that I can just rely my diagnosis on. I really have to have lots of EOs and lots of inflammation. My biggest differential diagnosis here, of course, I have to rule out GIST because GIST always comes to my mind in terms of location, but the other one is basically myofibroblastic tumor, because it's kind of similar, but it has very, very, very less sites, EOs here. Let's see the immunoprofile. It's positive for CD34 and the PDGFR. And if I look at the differential, they don't have just there, but they have myofibroblastic tumor. And just by going high power, you can see I don't have EOs in my myofibroblastic tumor as much. You can see a few scattered here and there. These are even blood vessels. And for IMT, basically, I'm not too, I'm not a soft tissue pathologist, but for IMT, I believe the most important thing is you have to see those atypical myofibroblasts, or not atypical, just the myofibroblastic scattered, these.
And I think you see lymphocytes in IMT when compared to eosinophils and the inflammatory fibroid polyp. It's very like scattered.
Scattered lymphocytes, okay. Which you can see here, plenty of them. Okay. All right, moving on to the next case, and case number 32. Looks like it's an appendix, right? Again, in your appendix, you will have your two tip sections and then one margin and one representative. So let's see on low power, what do we have here? Epithelium, I want to make sure I don't have a mucinous neoplasm here. Let's look for carcinoid. Oops, what are these glands? Those don't belong here. Let me see. More of it here. I will do a keratin on this one to make sure that this is, yeah, these are all definitely glands. Agree, girls?
Yep.
Agree? Yeah, so this is abnormal.
Plenty of glands.
Proliferation.
Plenty of glands.
Yes. So
question is, it looks like it is coming from outside or something?
yeah, one thing I want to make sure that, first of all, on low power, it doesn't look like endometriosis to me, but it comes to my mind. But it doesn't look like it because I don't have that spindly stroma around the glands. And the glands look, they're funny. They're funny, very, very funny. Okay. So honestly, I would do all the stains on Earth. I'll also do a synapto and chromo just to make sure I don't miss a carcinoid or a
goblet cell X
cell.
carcinoid is in differential too?
Yeah, look at that. This is goblet cell carcinoid.
Shit.
I know, right? Tumor clusters with vacuolated cytoplasm. Look at that. Wow. Wow, wow, wow. The case that I had of goblet cell carcinoid, it was not intact glands like that. It was
Yeah.
literally single cells.
Yeah, even
It
the
was
ones
like,
that I've seen don't look like this. They're all
oh
single
my
cells.
God.
No, like the one I saw in my residency was exactly like this, but it was like
Wow.
very widespread and it was like this. Yeah.
Classic. Oh my gosh. Yeah, no, the one I saw was like so subtle. Probably seven cells, I would say. And it was on a biopsy, not on a resection. Okay. So that's cool. So that's goblet cell carcinoid. Of course, you have to do your synapto and chromo. It will be very important. It will be both 7 and 20 positive. Okay.
I think the new term for this is goblet cell adenocarcinoma.
Yeah.
Yeah. All right. So let's move on to the next case. Again, we don't have the location, but let's look very ectatic vessels in the middle. And lots of skeletal muscles. No, that's actually axontic glands. Okay, gastric epithelium on top. But why does it look like that? Okay, so if that is, let's say, a stomach, we have goblets. What is this? Doesn't look like a stomach, but it is a funny stomach.
Is it a gastric heterotopia with like,
Where do I have other things other than the gastric epithelium?
it's the surface.
The surface is all gastric, but yeah, it could be a heterotopia for sure, because the submucosa for the submucosa here is not a gastric submucosa for sure. You know, it's absolutely not a gastric submucosa. So let's see. I'm not gonna waste my time. But before moving on, I want to make sure that I'm not missing. I even if it's just a teaching session, I'm just so I cannot. I'm so obsessed by screening my epithelium. Sorry.
Yeah, that's always good practice. Yep.
Dr. Alsaati,
will
in
remember to-
in gastric antrum, when you look for IM, how do you differentiate it's not some portion of duodenal mucosa that has been like plugged in the biopsy?
Okay. So pretty much when you have an antral mucosa and it's labeled as antrum, we have to believe the clinician. Okay, number one. If I have IM and I pure duodenal, like I have Brunner's gland with villi and Paneth cells and everything that looks like a small bowel, I circle it on my slide and I say floater or contaminant. I don't even bother mentioning it in my diagnostic line because it is a classic duodenum. And I know that the doctor went into the duodenum and he took another bite of duodenum and I have another piece of it somewhere else. Okay. All right. But if I have something wishy-washy, I'm not sure if this is a duodenal piece or like a floating villi of a duodenum versus a true IM, I would rather call it than undercall it. Okay.
Oh, okay.
I would do that because I want the patient to come back for follow-up. And it's the only focus. Like if my other stomach is completely clean, I have nothing. But I can't really tell. I mean, this doesn't look like a duodenum, but however, it doesn't look like a stomach. So I would go towards calling than undercalling. Okay, doesn't matter. Let's bring the patient back for follow-up. Let him do a cleaner biopsy next time. We will clear him and he will be fine. There's no IM, and that's great. But something like that, you can't really just use your judgment and say, you know what, I'm not gonna call it. Again, the only time I do when I have very, very beautiful villi with Brunner's gland, and I'm sure it's coming from the duodenum. Okay.
Okay.
All right.
Thanks.
No problem. Let's see the case info here. And this is rectal, gastric. Oh, rectal. That's why I have all these ectatic vessels. All right. So presence of gastric type mucosa, antral and fundic type. Adjoining colonic mucosa. Unfortunately, I don't see colonic mucosa here. He didn't even highlight it, so I don't think that it's on this
There's
section.
a very small fragment on top.
Let me see.
Further up.
Further up.
The Diverticulosis. This one, I thought. No,
Mm-mm, not yet.
not good.
Oh, well, no, not yet. This is, oh, yeah. There you go. There you go. Yeah. No? Yeah. I actually can't tell. It's so cauterized here. I don't think so yet, though. Well, maybe yes. Oh, here you go. Isn't that squamous? There you go.
Teeny bit squamous, and then you have
And
the
then goblets.
yeah.
Yes.
It's just a little.
Thank you very much.
Cautery
Yeah.
or something.
So again, this is all flying up there, but I would rather have it here. You'll see the more you practice in GI, you'll see that you will have lots of floaters, lots of let's say dysplastic glands flying on top. It will change your diagnostic line. You won't be able to say, let's say there is low-grade dysplasia here. You won't say low-grade dysplasia arising in a gastric heterotopia with IM or something like that. If because it's flying, it's detached, again, one is not very, very comfortable, attaching them mentally without seeing it properly on the slide. This is a bit detached to me, but definitely if they called it a rectal biopsy, I would go with the heterotopia. What is this? This is gastric metaplasia. Okay, so this is another cool one. When do you call it heterotopia? When do you call it metaplasia, right? So this is definitely anosquamous junction mucosa. And then we have, let's say, let me just, boom, here. Okay, you have gastric foveolar metaplasia. Why am I calling it gastric foveolar metaplasia and not heterotopia? Because I don't have oxyntic glands. Okay, if you don't have oxyntic glands, this is not a heterotopia. This basically is a metaplastic process. Okay, and same thing exactly in the duodenum. I have plenty of heterotropias in the duodenum, probably 3 or 4 a day. And when I see them, it's not peptic duodenitis. I have to call this what I do is I go deeper in my slides. Whenever I see foveolar metaplasia in the duodenum, I go deeper. I want to make sure I'm not missing oxyntic glands. Once I see oxyntic glands, my diagnosis switch from peptic duodenitis to gastric heterotopia. Okay, and if I went deeper and I didn't see oxyntic glands, I'll keep it as foveolar metaplasia or gastric metaplasia or peptic duodenitis. Okay. All right, case 34. What are we looking at here? All right. This is colon. Oops, nice dilated glands in the bottom. I wonder if this is a flat sessile. Okay, that's nice. That's classic. Sessile serrated adenoma, hopefully. So this is a nice one. Let me just tell you some observation from my end. I have noticed that a lot of sessile serrated adenomas, this doesn't have a lot of deep submucosa with it, but a lot of them, they come with lymphoid aggregates at the bottom of them. Like let's say here, you will have a big lymphoid aggregate here. Sometimes when I see lymphoid aggregates in the right colon, I always go deeper. I want to make sure that I'm not missing an SSA. So it goes both ways. Sometimes lymphoid aggregates triggers me for deepers to rule out an SSA. Okay. Let's see what the case info is. There you go, SSA, and then so you will show. Let me read this out loud. Serrated polyps showing exaggerated maceration in the form of sawtooth appearance of the crypts, commonly in the right colon. The crypts are dilated right up to the base and show L-shaped or T-shaped crypt base. Let me click on this. All right, so the crypts show branching and horizontal L or T shape at the base, inverted maturation showing goblet cells at the base of the crypts, and mitosis at the higher middle crypt. All right, so you'll have more of a epithelial proliferation at the tip and the goblet cells at the bottom. When you see an SSA, in your head, your checklist is, it's not like SSA move on, it's SSA rule out dysplasia. Okay, that's how your thought process is. So it's a precursor lesion, and basically these are, you have more common MSI instability in it rather than the TAs, so it's more common for it to become a dysplastic process. So rule out dysplasia. So the way I rule out dysplasia is I look at architecture first. This looks all okay. I don't have crib reforming, and then I don't have darkness, okay? When I have darkness, I go much higher, which is, I'm talking about a low grade to a high grade. Now, again, they do not anymore differentiate between low and high grade in serrated adenoma, but I still do in my practice. I feel like I mean, I like to call it low grade versus high grade, but although management doesn't differ at all. Okay, this doesn't look like it's dysplastic. Let me go back and see. We did the microscopic. Distinctive molecular phenotype, high levels of CpG, island methylation phenotype, CIMP, BRAF oncogene activating mutation, and high MSI. Yeah. All right, so let's move on. Oh no, yeah, case number 35. All right, so this is, let's see. Oops, I have displaced glands here. Some sort of adenoma with displacement. Or let me make sure. Okay, let's see where we are first. It's a tubular adenoma of the colon. And then we have inward growth. Is that invasion high grade? That's the one thing you want to make sure. Or is that displacement? See how rounded? Okay, this is bread and butter of GI, girls. I'm serious. This is so common, and it's almost a day-to-day dilemma for us when you have an adenoma. First of all, let me make sure that we're talking about the right thing. Yes, so this is a tubular adenoma, and I mean, you see where that gland is? It's all the way down in the submucosa. It's to your eye or to our eye, it should be not normal. But every group is surrounded by lamina propria. Look at that. Every group is surrounded by lamina propria. And it's so rounded. The surrounding is so rounded, not pointy. I mean, look at that. Okay.
Yeah.
I'm not telling you this is easy. I think this is one of the most difficult aspects of our field. No, it's actually one of the most difficult aspects. I'm not joking. It's innumerably, I've sent cases to Stanford to figure out what's going on. And this, you see how that group here is sitting. It's surrounded by, still you have your lamina propria around it, and you still have the muscle beyond it here. And I totally favor pseudo-invasion in this one, pseudo-invasive process. Now let's see if we have hemosiderin. Okay. Lots of bleeding, lots of hemosiderin. What does hemosiderin tell us? This is all hemosiderin. Hemosiderin tell us that this is a chronic, slow process. When I don't have hemosiderin, I have a quick, aggressive process. Okay, it's not 100%, But for the most part, when you have hemosiderin, that means that a group of glands, when they tried to be displaced, they disrupted the vessels, they disrupted the muscle. However, it's been going for 2 years or 6 months, okay? When the tumor invades, it's much quicker. There's not enough time for the hemosiderin to collect, and it basically just goes through and erupts and invades in a much quicker manner. So let's see what's your, okay, low-grade dysplasia, pseudostratification, reaching the one half of the cytoplasm.
Yeah.
See that? Okay, high-grade dysplasia, pleomorphic nuclei reaching the luminal aspect, epithelial displacement. Let me see if, okay, no, so he is describing the difference between high and low. Let me see if he found high here. Sorry. I don't have high grade here. I don't see high grade yet. And my glands inside are not cribriforming enough to call it high grade. This one, I will call this tubular adenoma with atopia, with associated prolapse / pseudo invasion process. Okay, this is how my diagnostic line would say. All right, epithelial displacements, lamina propria surrounded by epithelial islands with hemorrhage, hemosiderin should not be diagnosed as invasive adenocarcinoma. This is very important. So of course, his differential is basically sessile serrated adenoma. I understand this polyp is not pedunculated, it's more flat, and you want to make sure that you're not missing sessile serrated adenoma, which we know how it looks like, right? It's more, it's less atypical, but this is SSA with low grade. Okay, the one he has here is SSA with low grade. See that epithelium is so stratified, but again, you go at the base and you see how, okay, when do we call SSA with low grade? And when do, not when, and when we call it tubular adenoma? You have to have classic SSA, okay? So here, you know, you have a low grade process, but you have to have a classic part that looks pretty much very purely SSA, okay? To call it. Otherwise, TAs will have some serrated changes nearby. Don't worry about it. Okay, let's move on.
And it's been a while since I did GI, but I remember making the diagnosis of, like, during my training, intramucosal adenocarcinoma. Is that, I think that would be a difficult one.
No, actually, this is not difficult at all. The reason is the terminology is no longer of use. We don't call it intramucosal. So intramucosal adenocarcinoma is tubular adenoma with high-grade dysplasia. Okay? Whenever you have high-grade dysplasia anywhere, this is an intramucosal carcinoma. That's why we don't use that term anymore. The only time I use it is in my Barrett's and my stomach. I call it gastric mucosa. Or no, I would start with at least intramucosal carcinoma. That means I'm telling the doctor that I have high-grade dysplasia in my gastric epithelium. I cannot rule out invasion, or it's not very clear for me whether, or maybe the patient will have invasion. You need to get more biopsies, okay? But yeah, we don't, high-grade dysplasia in colon is basically intramucosal carcinoma, and that's why we don't call it anymore. We just straightforward call it high-grade dysplasia, okay?
Okay.
All right, so let's move on. Case number 35. Or did I do 35? Yeah, we did 35, so 36. Okay, little tiny itsy bitsy. What's the location? Stomach with IM, or cardia, or GE junction. Let's see what we are. Columnar metaplasia of esophagus with goblet cells. Okay, so this is the Barrett mucosa. Okay, so again, I will call this columnar type mucosa with goblet cell / intestinal metaplasia. Say comment in the comment section. I will say this represents Barrett in the appropriate clinical and endoscopic settings, because the doctor should know where he got the biopsy from. Otherwise, this could totally be an antral mucosa with antral IM. Okay. Now, when I look at Barrett, again, that's actually a good place right now to differentiate between complete and incomplete. If you want, I can give you a quick overview. The goblet cells, basically, well, we do complete and incomplete mostly in the intestinal metaplasia of the stomach, but this also works perfectly. You see here the foveolar epithelium of the columnar mucosa, and then you have a goblet cell. Okay, that's the definition of incomplete. All right, goblet cells, more, let's see more. Foveolar epithelium in the inside, and goblet cell. Let's see more, which is more classic for Barrett's. Foveolar epithelium everywhere, foveolar epithelium, and goblet cells. Take a mental picture of this and imagine it in the stomach, okay? And in the stomach, if you have that foveolar epithelium, which is not switched into columna and not switched into intestinal, it's not eosinophilic, you still have those foveolar cups or mucin caps, then this defines incomplete type. Okay, and it's worse. If you have an incomplete type, it's worse for the patient. He needs to come further. However, it is not yet established that we have to differentiate it, but some doctors do believe so and they ask for it. Okay.
Is there a low-grade dysplasia in here?
Yeah, I was thinking about that, the same thing. Dysplasia in Barrett's, my threshold is so high, I wouldn't call this at all. My eye will ignore, let me tell you what I ignore. I ignore all of this, okay? I ignore all of this. The only thing I look at is the very, 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 very tip, okay, here. All right? The only thing I look at is the very, very, very tip. I keep going, I keep going. I still have the mucin cups. All right, and I do deepers very frequently in my esophagus. And none of them, the stratification reaches the top. Even here, if you go deeper, you'll feel that it's continuous.
Was it not in one of the deep crypts, like it was more pencilate going like through the tip, like it was like
Here,
crypt dysplasia? I have heard that term.
Yeah,
kind of
yeah.
here, yeah.
Deep crypt dysplasia, I agree with you. There is that term. However, I am not one of those who believe in it. So I don't, I mean, if you're gonna take deep crypt dysplasia, you will almost see it in every case.
Yeah,
it's so common. So I am very, I'm a strong believer that the tip is the one that has to tip you off, whether or not to call it dysplastic. Okay. So this is Barrett mucosa, and differential diagnosis is, what's my differential? Oh yeah, gastric cardia again. So the location is the one that has to be giving it away. So the clinician has to make the diagnosis. All right. Let's take a sip of coffee. My son got me. Wonderful, thank you. All right. All right, next, let's move on. Oh, before moving on. So this is gastric cardia. Intestinal metaplasia of the gastric cardia. Hold on, don't you see it? Squamous? Okay, so it's a GE junction mucosa. And you have plenty, I don't know, I'm not sure what we're looking at here. To me, this is a lot of squamous metaplasia. Okay, I'll move on. If I don't have good descriptions, I don't want to waste my time and yours. Okay, let's move on. Case number 37, correct?
Yes.
Okay. Case number 37. Where's my epithelium? Again, as you can tell, I always jump to see my location and I don't have epithelium. Obviously, I have a muscle here and I have, oops, where did I go? A muscle here and a soft tissue lesion, agree? So let's go higher. I mean, I don't even have to go higher. What is the stain I'm doing? I am doing a dog 1 on this one, or a CD117, right? I have to rule it out first. This to me does not look okay, and it does not look happy. And I want to make sure that I'm not missing a gist. It's on high power. It's not as spindle. So this to me looks very epithelioid. Look at these ugly cells. This is a mitosis. This is very ugly cell here. I would definitely make sure that I'm not dealing with a just pretty much epithelioid type. Let's say the case info. Where are we? Okay, so it is a gist. Arise from the intestinal cells of Cajal. For those who will be taking the boards, this is a common question. Patterns of spindle cells, epithelioid, mixed spindles, and epithelioid. Perinuclear vacuoles seen in gastric gists. A lot of them. Right next to the nucleus, you'll see perinuclear vacuoles. For me, I see it most commonly in a spindle type. You'll see a lot of like small bubbly vacuoles next to that. Sphenoid fibers, I had one case with collagen fibers seen in small intestines. I had one case actually, the sphenoid fibers helped me a lot in my cytology because they were like so pink and collagenous, and they were like right next to my spindle cells. But yeah, so sphenoid fibers are also nice and seen. I don't see them here. Seems like this is a gastric gist. So what's my immunoprofile? Remember, they can be SMA positive. Okay, so if you want to do a Desmond to rule out smooth muscle differentiation, CD34 dog 1 117. So you're good with these. Your differential diagnosis, of course, is a leiomyoma. And my leiomyoma will be much spindly and less blue. Okay?
That's the same case we saw yesterday.
Yeah. And now moving on. By the way, on a biopsy, I don't do a lot of description on my gists because I always ask them to do grading based on the resection specimen, because it can pretty much differ a lot from small biopsies to the entire section. All right, we have colon. We have lots of disruption of the epithelium. It doesn't look clean, the epithelium. Let's see if there's activity. Yeah, so bleeding, hemorrhagic, almost ischemic-like. Let's see what we have here. So what am I looking at? I'm looking at the epithelium. I'm looking if I have dysplasia. I don't. But here it looks like eroded. Look how the epithelium on the top, it's eroded. It's almost like it's like burnt out somehow. You see those little balls of vessels, as if there was over here a gland that is gone.
Mhm.
I wonder if the patient had any injury to this, or look at that here. Yeah, I don't like the epithelium. Sloughed. In another word, the epithelium is sloughing or dying. Look at that here. This is very good. You have the collagen and the collagen or hyalinization of the lamina propria, we call it, hyalinization. You see that here, that artifact. To me, when I see that inside, that means the membrane or the surface lining is disrupted and the fecalith material was able to invade inside. Okay, so it's let's say a chronic process if you see those um, artifacts deep inside the fecalith material. Yeah, obviously here I don't have any epithelium, it's all burnt out. The one thing that comes to my mind is ischemic colitis, or if the patient has, you know, a cancer and he had a surgical removal, and this is a site of removal, or radiation induced, or yeah. So I definitely have this whole area here. We lost the mucosa. Okay. Okay. So it's just to me, it's going to be a differential. Okay.
Yep.
Let's see what we have.
Yeah. Ischemic
Chronic
colitis.
radiation colitis. So again, let me see if this is a chronic case. Let me see if we have the abnormal stromal. Yeah, see this one here? This cell here, of course, not based on one cell, I will do it. But now that they called it radiation-induced colitis, you will see the abnormal stroma. Look at these prominent nucleoli. See them? Lumped cells with prominent nucleoli. These have to trigger your thought process of calling it radiation-induced. Okay? Okay, what do we do here? We definitely do a keratin. Okay, because the patient has probably prior history of cancer. So we need to make sure that we don't have any infiltrating cells in the middle. So looks similar to ischemic. Two forms are identified, acute and chronic. Acute crypt loss, increased apoptosis, increased mitosis, and eosinophils. This is the acute, okay? Chronic is hyalinization and atypical fibroblasts and bizarre endothelial cells.
And that's what we have here. Yeah.
We do have that here, yes. And in the chronic, both acute and chronic, you will have crypt loss.
Loss, yep.
And here, look at that. This is a beautiful, like it's just almost like a granulation tissue. All these crypts are gone with a lot of inflammation. Okay, and I don't think there is a 30, what, for this one, 39. Okay, let's do 39. 39 is, any takers for that invagination? Diverticulosis, right? It's just like literally the muscle is cut in half and you have the tick going through it. What do I look for in diverticulosis? I definitely don't want to miss an adenoma. Innumerable times, the biopsy is from a diverticulum and I find a small tubular adenoma there, growth, okay? So make sure you don't miss that. And what else? That's it, simple. I think this is the diagnosis, let's see. Yep, diverticulosis of the colon, outpouching of the mucosa and submucosa through the muscularis propria, muscular hypertrophy and fibrosis. This is pretty much thickened and fibrotic. For those of you who remember during residency, we used to gross lots of these. I remember I used to put my probe inside the tick here, and then I used to cut through the like I used to put my blade perpendicular to the probe, I was a little bit crazy in grossing. I know even if it's so simple like a tick, but I used to, let's say if I have that colon with diverticulum, I would lay it flat and then I would pin it and then I would actually let it fix in formalin, and I will do it at my last case. So instead, let's say if I have 10 cases, I'll do it my last case. This way I'll have a nice section of the tick. I was, yeah, I don't know. It's just, I used to like grossing them. Okay, next is 40.
40.
Okay, let's see, case number 40. Oh, come on. Okay. Where are we now? I think we saw that yesterday, right? Isn't that the juvenile polyp? It was part of comparison between
For the inflammatory polyp.
Yes. So again, the most thing that strikes you in this one, there are much better pictures than this, but for this one, I think the cystically dilated deep crypt. So you have just a big dilated duct here. I'm sorry, gland crypt. And let's see the case info and the juvenile polyp, and it is hamartomatous polyp, cystically dilated, separated by loose edematous stroma, variable degree of inflammation. And for your differential diagnosis, it's the inflammatory polyp. We went through it already yesterday. Okay, so next is case 41. And let's see what we have here.
Oh,
I know, right?
yeah.
Okay, strongyloides is the bug of choice here. Let's see your case info. Oh, just to let you know, let's look at the lamina propria and see the amount of EOs, okay? That's why EOs are around there. So we need to make sure that we're not, when you have EOs, go deeper, look for your worms and bugs, okay? So it's a nematode larva form. Eggs and adult forms can be seen in the tissue sections. Infection can resemble inflammatory bowel disease. Neutrophils and lamina propria without crypt abscesses, cryptitis. It can be a clue to strongyloides over IBD. So they're telling you that if you have neutrophils in the lamina propria without cryptitis or crypt abscess, so sparing of the gland, sparing of your crypts is a hint for you to look for worms, okay? Unlike the IBD, where you have your inflammation pretty much on the epithelium itself. Okay, differential, of course, is IBD. And hold on 1 second. My son is calling, 1 second. Okay, yeah, sorry, I'm back. All right, so this is IBD. No, what did it, yes, an IBD. And what, let's see where, I will need an active area.
We had better IBDs yesterday.
I know. But we have better IBDs yesterday. I'm pretty sure if I had see how there's a lot of chronic inflammation in the bottom. But yeah, so I wouldn't eat, I mean, what do you call it? I wouldn't think about parasites in this section. It's very clean to me. Okay. I don't know. I'm not able to call this.
We can leave it. We know what we are going to see. That's fine.
Okay, perfect. All right, let's move on. Next case. All right, sorry. Case number 42.
Mm-hmm.
All right, let's move on. And where are we here? Gastric, agree with IM. Show you the IM, sorry. Yeah, here's the IM.
Yep.
See, now we have, ooh, juicy. Juicy. I don't even have to show it around. This is a low-grade dysplasia, okay? And when I see low-grade dysplasia in the stomach, it's either, okay, here's the deal. Low-grade dysplasia in a stomach, I will look what the doctor saw. If it was a random biopsy, then then I look for, of course, I look for IM. I have gastric antral type mucosa with intestinal metaplasia and focal low-grade dysplasia. Next line, no high-grade dysplasia present, okay? Now, if he saw a polyp, this may represent a tubular adenoma of the gastric mucosa, okay? And then underneath that, I'll say background antral type mucosa with focal intestinal metaplasia, all right?
Yep.
So your diagnostic line really swings right and left based on what the doctor saw.
Yep.
So let's see. I have low grade and I have IM, and let's see what he called. Okay, he called it gastric adenoma. That means the doctor saw a polyp. All right, I cannot call this a gastric adenoma if I have a low grade, if I have IM in the background and the doctor's and it was a random. Okay,
That's correct.
if it was a random. Okay, here's the deal. A gastric adenoma is fine, but it will occur without IM in the background. All right. So if I have a IM background and I have gastric adenoma, this could be coincident. But if I have IM and I have what looks like an adenoma, but it turns out to be low-grade dysplasia, then the patient may have much, much more foci in his stomach. Okay? So that will trigger the doctor to go back. It's like, oh my gosh, was this really low-grade? I didn't see anything. Let me go back and do more bites and let's see. Because the reason is after that, it's high grade. After that is signet ring carcinoma, and we're in a whole other dilemma.
Correct.
All right. So crowded and cystically dilated branching and tubular elements lining epithelium with varying degree of nuclear atypia can be intestinal type or gastric foveolar type. This one here in particular is intestinal type. Low-grade dysplasia or high-grade dysplasia. Okay, this is all low-grade. Okay, good. All right, now let's move on. But while we're here, let me just show you. Let's grade. What was it? Case what? This one, 45. Let's do the. No, it wasn't 35. Good. Guys, remember what case was it? Let's see.
Which one?
41, I think.
Huh?
Which one?
The one I was just looking at. Is
41.
42.
42.
Yeah. I want to grade the IM with you. Let's. It's a nice practice for us right now to see if this is a complete or incomplete. Okay. All right. Let's see. This is very focal IM, very, very focal, right? But look here, you lost the foveolar epithelium, not like here. This is all foveolar, right? You have, but look at these deep crypts here. You have intestinal brush border. You have here intestinal brush border, no more mucin caps. This is a complete type. Okay.
Yep.
Very subtle, but probably it took me a year to master that. I'm telling you, girls, it wasn't something that came very spontaneous to me. Again, when you have both, this is here incomplete.
Yeah.
See that? The foveolar
Yeah.
is still here. So this one, to me, I will crowd it all together and I'll call it IM incomplete type. Just because I found this focus.
Okay.
If I didn't find this focus, this is a complete type. Now, I
Okay.
don't go deeper in all of my IMs. I'm not sure. That's why it is not recommended right now to differentiate. Because honestly, if you go deeper, you'll find the focus of incomplete somewhere, or you know what I mean? So there will be a lot of non-reproducibility between the pathologists. Okay, so bear with me. All right. So we have a nice submucosal growth of a spindled lesion that is likely going to be leiomyoma, but it could be a schwannoma, or it could be a gist with spindle cell differentiation. So I will purely do my immunostain. S100 positive.
Wow.
So what are we talking about? A schwannoma.
Schwannoma, yeah.
So exactly, gastric schwannoma, lymphoid cuff around the periphery. Let's see the lymphoid cuff. Yep, there it is. And features, it doesn't have the classic features of Verroque bodies and head-like vessels. Honestly, it looks like a leiomyoma at first. So that's why always do your stains. Don't take these things lightly. You'll be surprised.
I don't know. In my residency, I was taught like schwannoma in the like in the GI tract, they have a lymphoid cuff, and this one has that too, like those lymphoid aggregates at the periphery. That's a soft sign. I mean,
it's a
you
soft
definitely
sign,
need to do the stains, but that's something a soft sign.
Yes, it's very soft. But for instance, if you were thinking that this is a leiomyoma and you found those lymphoid cuffs, just go ahead and stain it. Okay. So it's a soft sign, but it's it triggers the thought process in your head. All right. Let's move on. Case 44.
So what are the stains that you would do? I mean, just to confirm, S100, SMA, and CD34.
I would do S100. I would do a Desmond in my practice, and I would do a dog one. These are the three states. So each one will stain something. If I have an S100, it's going to be a schwannoma, and it has to be negative for both dog one and Desmond. If I have only Desmond, it's a leiomyoma. If I have dog one only, if it's a gist. If I have dog one and Desmond, is the gist with spindle cell differentiation, with smooth muscle differentiation. Okay.
Okay.
Now, where are we here? Colon again. Some vessels, more of a lower. And okay, the epithelium here is not okay. You have ulceration, erosion, almost like a pseudomembrane. See that? So that's a nice, I think it might be a nice pseudomembranous colitis. Let's see, because you see how there is like
that even
the
flames.
Yep. See those.
The volcano appearance is like classic.
Yep, different terms.
Yeah. This one. Eruptive exudate containing fibrin, inflammatory cells, and mucin. And let me go to the pseudomembranous colitis. And for pseudomembranous, it's ischemic. Even without looking at it, I'll tell you how to differentiate. In ischemic, the lamina propria is much more involved than the epithelium on top, okay? So let me show you an ischemic side by side.
Exactly.
Look, okay?
Mm-hmm.
Ischemic colitis, lamina propria is pretty much inflamed, it's erupted, and then you have hyalinization, and you have the crypts, call it tethering of the crypts. So it's pretty much dying, tapering down to death.
And some degenerative changes.
Yeah. All right. Now it is case number 45. Let's see where we are here. Okay. I wonder if we are. So it's an upper, you have gastric, pyloric, and could be hyperplastic polyp. Look at that artifact. I bet it's from the embedding.
It's a chunk.
Yeah,
Wow.
so it could be, don't you guys think it could be a Fundic gland polyp?
Mm-hmm.
Let's see. Let's see. Cystically dilated glands lined by parietal cells, chief cells, and mucinous cells. And there you go. It's your Fundic, classic Fundic gland polyp. Okay.
Mm-hmm.
Now, where does my eye go? Again, I have to rule out IM. I have to rule out dysplasia. Okay.
Mm-hmm.
And based on my experience, I had one case with signet ring cell carcinoma, which keeps coming into my head every time I see a Fundic gland polyp, but nonetheless, doesn't mean it's common there, but I want to rule it out. Okay, but it's nice. It's a nice Fundic gland polyp. It's not dysplastic.
Now that you shared your experience, we will remember as well.
Okay, great. Thank you. That's all I need for now. All right. So this is case number 46. Okay.
Mm-hmm.
Our beautiful appendix. And in my tips, we want to rule out. What do we want to rule out?
See, there some things there. Is it another goblet cell?
Exactly. It doesn't have to be goblet cell.
No,
This is
it's a carcinoid. Most is it carcinoid?
Exactly. So I mean, the first thing I did is the tip and carcinoma because it is there. Okay. So let's go to look at that beautiful cords and glands. Okay.
No, this is more like carcinoid.
Yeah, this is more like tubular carcinoid and benign neoplasm, discrete compressed tubules involving the submucosa and the muscularis propria. CEA positive, synapto, chromo, and glucagon positive. Okay. Now, let's see if there is no differential. Say that again.
Do you do glucagon?
I don't know. I don't do glucagon. 47. I have to go a little faster here because I have something else to get to, but all righty. Quite bad, right?
Yeah.
That's what we would say about this. It's quite bad. There is IM. Where are we? I think this is
What is it? Is this benign?
I am not sure. Let me see. Microscopic. Non-neoplastic proliferation of Brunner gland.
Yeah.
50%. This is quite exuberant Brunner gland hyperplasia.
Yeah, exactly.
Or okay, that makes sense. It's Brunner gland adenoma, not hyperplasia. Yeah, it's quite exuberant. So duodenum with Brunner gland hyperplasia or Brunner gland adenoma.
It was probably diagnosed as a polyp or nodule or something.
Yeah,
So that's why they could easily give it the name adenoma.
Exactly. Otherwise, I would call this hyperplastic renal gland suggestive.
What was in the differential? Well, we can go fast if that's okay.
Let's see the differential. Brunner gland hyperplate hamartoma. In hamartoma, when they say hamartoma, I want to see muscularis. Okay, there you go. Okay.
Okay.
So that's how you differentiate when you see muscles coming through your Brunner gland. Okay. And this is the one next to it. Where are we? Let's see. We have glands, a colon. I'm sorry, guys. Can you hear my kids screaming or no?
No.
Okay, good. It's just me. I'm glad it's just me. All right. There's something here that's not okay.
Yeah.
Okay. All right. Beautiful, beautiful case. Beautiful case of, I believe this could turn out to be pneumatosis intestinalis. But let's see. Let's see more here. You have cysts of air spaces surrounded by multinucleated giant cells. The one at the very end is much better, this one. See how you have dilated airs, spaces, and then you have multinucleated giant cells all around it. This is your classic feature. Let's see if the case diagnosis. Yes, pneumatosis intestinalis, air-filled cysts with the bowel wall cyst lined by foreign body giant cell histiocytes. Okay? So moving on. And 2 more cases to go. That's it. All right, let's see what it says here. Okay, we have gastric epithelium. We have, oh, this is a beautiful AMAG. Okay, so, all right, so location of this biopsy is very important, whether it's the body or the antrum. So what triggered me to call this AMAG? Well, let me see if I'm correct first. Yes, so the reason I'm calling this AMAG is your eye will be able, once you see more and more of these, you know, I have chronic inflammation, and this was at some point an intact oxyntic group that antralized. Look, even this one. A small focus of what may have been an oxyntic was antralized. Now you look at low power and you see like you have almost like aging of that what's so-called body type mucosa. You see here these oxyntics are almost dying in the background. Again, don't forget your artifact. And then here it's almost like cystically dilated, what's so-called to be oxyntic. Yeah, that's a beautiful AMAG. So oxyntic gland atrophy with dense lymphoplasmacytic infiltration, bottom heavy infiltrate, dense eosinophilic infiltration is in an early phase. It's very difficult to diagnose its older phase anyway. You have IM and pancreatic acinar cell metaplasia. Let me show you pancreatic acinar cell metaplasia. I don't see it though yet. I don't see it here, but if I saw it, it's going to be very nice and classic.
Yeah, they haven't highlighted it on the line.
I can't hear you.
They haven't highlighted it yet. Can you hear me?
You're very soft,
Are you putting headphones on or something?
Are you on speaker?
Are you able to hear me now?
Yep, much better.
Yeah, they haven't put the hyperlink on that. Probably they don't
Yeah,
have it.
so there might not be. Linear and nodular enterochromaffin cell hyperplasia. I wish we have, I really wish we have a synaptoautochromo to show you how they look. And absence of G cell confirmed to the gastric IHC. If this is a beautiful case, ladies, I have to be honest with you. This is a beautiful AMAG case. If I have my stains, I would have showed you that the gastric stain would be dead negative in all of these 4 pieces. And the synaptophysin or the chromogranin stain will highlight enterochromaffin cell hyperplasia. And it would be, show you. Make it up. You can see them here. Those will grow, linear and nodular. Okay, linear and nodular type. All right. So this is a nice case. Always keep that in the back of your mind. I know some of you haven't seen it a lot, but it's more common than you expected.
We are just
Helicobacter gastritis is one finding because it might cause atrophy of the body. So always do an immune stain. And if you have both Helicobacter and you're suspecting AMAG, do not diagnose it without doing your chromogranin stain. Okay. Uh-oh.
Don't worry about it. We are hardly able to hear your background. It's very, very faint. It's hardly.
Hold on, baby. Mommy's almost there.
Okay. All right. So this is the last one. Low power diagnosis, Peutz-Jeghers.
Yeah.
Okay. Low power diagnosis. You have that muscle proliferation into that tibialis look to it.
Yeah.
And your diagnosis has to be done based on your histology on this one purely. You just have to follow your course and see that the muscle reaches all the way to the top. Okay, let's see if I'm correct. Yeah. So type of hamartomatous polyp, it's papillary architecture with arborizing smooth muscle bundles dividing the polyps into vague lobules. And honestly, you can see that in TVAs and stuff, but you really want the muscle to reach the top. Okay. The very, very top of your Peutz-Jeghers. And your differential is a hyperplastic polyp, and there it is, and the muscle stops here, as you can tell. It doesn't go all the way up. Alrighty?
It's a great.
Okay, before you go, I want to catch you. Before you go, I want to catch you. So I know there are few places which might have more of gastric slides, and one of them being libre pathology. I don't know if you have heard of that, but they have like tons and tons and tons of slides. If I pull out some slides, will you be able to go over them? Like maybe we can pull out some cases which we haven't seen as yet, or which are not so usual. That will be so that you don't have to pull out your own cases. You don't have to put like a lot of work into it. You can just see those cases and you can just describe and teach us those cases. Will you be able?
And what to be honest with you, I'm very interested in teaching, so I will be setting aside some slides on a daily basis.
Yeah.
I can text you. I'll tell you I have a collection of 10 cases. Let's do a session. Is that okay with you as well?
Yeah, definitely. That's definitely. I mean, not the usual cases, the unusual cases that you get, or the hard calls that you get.
Yeah. I'll do that. And if I had the classic AMAG, I'll also share it with you.
Sure.
And what else? I will also have you guys. And I'm fine with doing liver pathology. Yes, of course, I know liver pathology, and you can just text me the
cases,
section or something that for me to look at. take a quick look and we'll do another session.
What
That's
time
fine.
would suit to you? Like the same time, 4 to 5:30 over here. That would be like 1 to that usual time of yours. Will that work with you?
Yeah, but not so hold on. Are we done with the GI block? Are you
We are
done
done with the GI with what we had thought that we had to do.
Okay.
But given your expertise, I'm being more hungry here.
No, I'm fine, but I cannot do it every day right
Yes,
now.
yes.
I can but 1 to 2:30 is perfect for me. But
Okay,
yeah,
just let
but
me know when you are available,
yeah,
and we'll keep that section, like that particular day for you.
okay.
And
Sounds
we'll
good.
take, yes,
And
yes.
please feel free to text me if you have some cases you want to share with me. If you have something, weird.
Yes, yes.
I would like to learn from you guys as well. So it's a two-way process. Okay.
That's great. So the next topic is going to be liver, you guys. And unless Dr. Alsaati has cases on Monday. So if she has
No,
cases,
Monday is gonna be challenging. I'm not,
yeah,
but
yeah.
liver, I'm interested in, but I really don't know anything about it. So I might
No, I
be
will try
joining
to
on
get
mute.
Dr. Aki into there.
Okay,
And
I might
if
be joining on mute. So
sure.
yeah. So just
Thank
to
you
hear
very
in the
much.
Thanks a
background.
lot, Doctor.
No worries, no worries. Nice to meet
Thank
you,
you
ladies.
so
All
much.
right,
Thank you
take
so
care.
much.
Take
Bye
care
bye.
and have a nice day.
You too. Bye
You
bye.
too.
Thank you.
Thank you. Bye bye.